here at Emory. She'll be talking about neuropsychological changes, temporary and permanent. I think Emory is pretty unique. Maybe not, I don't know if lots of them are doing it now, but woo, Emory. Dr. Yakomeshku several years ago started sending patients, any patient that was willing to do it, to the neuropsych department to do the testing. And I didn't know what she meant, but I was like, sure, I'll do anything. When I first did it in 2014, I don't remember. It's like brain games. It's so fun. You just sit there for hours just playing games, and then afterwards you get this report that's it's very interesting to read your summary after you've done all those things. It was so much fun. I don't know what Laura's talking about. It was the best thing ever. All right. Why is it not hooked up? Oh, because I didn't put the HDMI cord. Okay. So that just advances it, not like a pointer.
Great. Okay.
Thank you.
All right. Oh, you're assuming I'm tall. I like that. Good morning, everybody. So I'm Dr. Suzanne Penna. I am a neuropsychologist working at Emory Rehab Medicine. Can you hear me okay?
Sorry.
Yeah? Oh, hey, a car.
No, I don't know what's.
Uh-oh, it's not coming up, is it? Give us just a minute.
Move that over there. You can start talking.
Okay. All right. So are people familiar with what neuropsychologists are and what we do? Okay, great. So I have a PhD, not an MD, and essentially I was trained as a clinical psychologist with a specialization in brain and behavior relationships. So I can talk about feelings. I typically don't. I really kind of live in the world of neurology. So I really look at assessment of thinking and emotional functioning following brain injury or disease. And I'm specifically interested in medical conditions that affect brain functioning, particularly thinking. So many years back, Dr. Iamescu contacted me and said, you know, we've got all of these people that I see with Cushing's disease, and, you know, people complain of residual problems with emotional functioning, residual problems with their thinking, even though they are in remission, their tumor's gone. We don't know what's going on. The literature is very unclear on this. Will you see these people? And absolutely. So that's essentially what we've been doing over the past several years. As Leslie talks about, the testing is not invasive, so there will be no neurosurgical procedure shown today. It's a little much before lunch, and basically it's a lot of pencil and paper testing because, you know, you all have had a lot of neuroimaging. At this point, everybody has a very good idea of what their brain looks like, but the open question is, how is your brain actually working? And scans at this point really can't tell us that. The best way to see how your brain is working is to make it work. And that's what we do in neuropsychology. Some people really enjoy it. They're like, oh, this is fun, it's like school. Other people are like, I would rather have surgery again than do this. So your mileage may vary. And I think the reason why we do this is because there is a lot of unknown, particularly long-term after Cushing's disease. So, you know, my goal here is not to terrify anybody. My goal here is to actually provide some reassurance and to talk about some of the mechanisms, both physiological and psychological, that can underlie some of these symptoms that people have. So I'm going to talk about this, you know, cognitive changes, psychological changes, both during the course of Cushing's disease and then following remission. So I apologize. So I'll just briefly tell you what I'm looking for. You're a very savvy audience. You guys are very, more so than most, knowing kind of what hormones are involved, what they do, you know, so I have this, the intro may be a little on the basic side, and I apologize, bear with me, because I don't want to leave anybody behind. I want everybody sort of to be able to understand what I'm saying, and I apologize if it's a little, not up to, I guess, medical speak, if that makes sense. Okay, so what I'm looking for is I want to explain the role of cortisol in neuropsychological problems associated with Cushing's. I want to discuss the research findings regarding temporary and long-term psychological problems with Cushing and cognitive problems with Cushing's, because often these are very much intertwined. I also want to talk about specific findings from the Emory clinical Cushing's population and then end with next steps. And now the reason why I am talking a lot about the Emory clinical population is because there is not a lot of research on this. Cushing's disorder is relatively rare, and long-term outcomes have not been very well studied, particularly given about the cognitive and psychological changes that are associated with it. So there's not a whole lot out there in the literature. I'll summarize what is there. But that's also why I'm relying on sort of what I've seen clinically. I know it is somewhat less scientific, but again, when there's not a lot of information out there, you really want to pull from whatever is available. And so I want to give you kind of both what the research says, both what we're seeing clinically, and then again, where do we move forward in the research? I will say Dr. Iamescu and I have tried for many years to try to get funding to do further studies on this. I can tell you exactly what studies need to be done. However, the funding agencies we've applied to do not agree that they are as necessary as we believe they are. So I'm like, I think, what am I, 0 for 3 in terms of grant funding on this? So, but I'm still trying. Okay. All right, so starting at the very, very beginning. And again, this part is probably a review for most folks in this room, but I'm going to do it anyway. So just a brief overview of the human nervous system. We've got your central nervous system, which is the brain and the spinal cord. Then your peripheral nervous system, which is the rest of it. Your peripheral nervous system is really divided into 2 parts. You have your somatic nervous system, which is involved in voluntary movement, and your autonomic nervous system, which is involved in involuntary activities. It's the autonomic nervous system, which is what I want to focus on today. Specifically, the 2 branches of the autonomic nervous system. You've got your sympathetic nervous system, which is the fight or flight. You know, when you're under stress, when you're activated, it gears up. When the danger has passed or the alarm has passed, the parasympathetic nervous system kicks in. This is your rest and digest system. Before I continue, I do want to let you know that I'm sending all of my slides to Leslie, so you will have access to all of them. They're yours. So, you know, feel free to just listen if you want, but, you know, feel free to also take notes if you'd like to as well. Okay, I like pictures. So basically the sympathetic and the parasympathetic nervous system work opposite each other. So when the sympathetic nervous system is activated, your pupils become dilated in order to kind of, you know, prepare yourself for whatever stress that may happen. It inhibits salivation. It decreases your digestive, your digestive movements because it's diverting all of that energy into your muscles in case you need to do something. And the parasympathetic nervous system essentially reverses this. So these 2 systems are basically at opposition with each other, and they serve to manage your body's homeostasis, which is just basically your steady state. And homeostasis really is a balancing act between activation and rest. And so what happens in Cushing's disease is this homeostasis becomes disrupted in favor of the sympathetic nervous system. So that body's fight or flight system remains activated. And as you can imagine, this causes problems. So just to kind of put it holistically, this is the entire, this is the system that becomes unbalanced in Cushing's disease. All right, so what happens when we encounter a stressor? So when our sympathetic nervous system is activated, what happens? So you detect a stressor in the environment. It can be a test that you have, taxes are due, a bear in the middle of your backyard, whatever. Stress triggers the response of the hypothalamic pituitary adrenal axis, which is your neuroendocrine system. I know people here are probably intimately familiar with the HPA axis at this point. This sets off this cascade of signals that ultimately leads to the release of hormones and neurotransmitters, specifically cortisol, norepinephrine, which is noradrenaline, and then epinephrine, which is adrenaline. Okay, so this is what happens. So your sympathetic nervous system activates, HPA axis basically fires, cortisol is released, and then when the danger is over, when the stress is over, it downregulates. So a signal goes back to your brain, the danger is gone, the parasympathetic nervous system essentially turns on, turns off the flow of cortisol, and your stress response is over. Okay, that's how it's supposed to work. So basically, cortisol is your main hormonal mediator of stress in humans. And like I said, stress could be anything, and it's usually it can be produced internally. I've got this huge deadline tomorrow, you're secreting cortisol. There's a bear in my backyard, that's an external stimulus, okay, that's secreting cortisol. And it results in behavioral changes of increased vigilance, alertness, attention, and these are good things that allow us to cope with stress, if it's temporary. It is not temporary in Cushing's disease. Prolonged cortisol excess leads to physical and behavioral abnormalities, as does this chronic secretion of cortisol. So this is essentially the basis of these physiological and behavioral changes in Cushing's disease. So as you know, Cushing's is really the extreme example of the cortisol hypersecretion, basically out of control. So this system never turns off. And essentially your body is preparing for, something that never actually happens, and it's continuous. And so obviously this has physical effects, which people are all familiar with, and it also has cognitive effects and emotional effects. And this is the area where I sort of live, in these cognitive and emotional effects. So specifically, people have sort of this mood lability, like they're up, they're down, little things that never used to bother people before. It's like, I'm gonna bite your head off, like don't, like just rah, and that again, that's cortisol. That's what it does. Symptoms of panic, so your sympathetic nervous system is activated. What happens? You stop digesting, so essentially that sort of butterflies in your stomach feeling, that's what's happening there. Your heart rate increases, your respiration increases, and you think there's danger because your body is telling you there's danger. So then you think, okay, what's going on? And then because there's nothing there, that you can point to, you think, oh my gosh, I'm going crazy. And that's when the panic sets in. So, and again, this is all in response to the signals that your body is giving you due to this hypersecretion of cortisol. Is this sounding familiar to people? Yeah, does this make sense? Okay, so no surprise then, psychological disorders are extremely common in Cushing's disorder for really two reasons. I think a large part of it, and probably the majority of the reasons, is this hypersecretion of cortisol. So it's those hormonal changes that essentially are activating your sympathetic nervous system. So basically you are on edge all the time due to this dysfunction in your hormonal functioning. So that's a lot of it. But then a lot of it too is just a distress over the physical changes in your body. You're gaining weight. Your hair is falling out. It's growing in places it shouldn't be. Like all of these things. And, and because many times I've heard this over and over again, particularly from my female patients, it's taken a long time to get a diagnosis of Cushing's. And so when they go to the doctor and they say something's wrong, they're like, yes, you're depressed and you're fat and you're lazy. Yeah. Right. And so how's that going to affect our moods? Right, exactly. So you've kind of got this 1-2 punch of hormonal changes as well as these physical changes that people blame themselves for, particularly when there's no diagnosis, or they get blamed for. Of course that's going to affect your emotional functioning. So, right, so, really we got to hit this on two fronts too. So, like I said, psychological disorders are extremely common in active Cushing's disease. The literature sort of ranges in terms of diagnoses. I've seen rates as low as 66% or as high as 90% incidence. So it's definitely a thing. Anxiety and panic disorder are slightly less common, and much less frequently, but I have seen it, is acute mania. Again, the cortisol, people just kind of, become manic. And I had this one patient, she was great. One of my favorite people, but she was very manic, and she was scheduled to have surgery 2 days after she saw me. And I said to her, we made the mistake of leaving her in our library to complete a questionnaire. And I came back in 25 minutes later, and my little model brain was in pieces, and there was like 30 books off the shelf. And I said, I think you're manic. She's like, I think you're right. I don't smoke, but I smoked a pack of cigarettes today. She did much better after surgery, in case you're wondering. Okay. But all of these things happen. And again, like I said, it's this combination. It's largely due to the physiological changes from the hypersecretion of cortisol, but it's also your own response to it, the emotional response to it that you have it as well. Okay. And because people think to myself, well, am I just lazy? You know, am I just making a big deal out of this? Like, am I overthinking this? Like, and no, you're not. But your brain makes you think that you are. And once the depression sets in, it alters the way you think, and it alters the way you perceive things. So you're more likely to blame yourself than you are the disorder. Okay. All right. So again, why is cortisol implicated in psychological disorders? Fortunately, we have a wealth of research on this in psychiatry. So again, the dysregulation of the HPA axis has been seen in individuals with depression without Cushing's disease. So very often in psychiatry, about 30% of people with depression and nothing else, no other disorder, will fail a dexamethasone suppression test. So they actually have biochemical dysregulation of their HPA axis with depression alone. Essentially because of, they don't have a hypersecretion of cortisol, it's sort of low level, but that it just never turns off. That sort of cycle is dysregulated. Also, we can induce depression in people when we give them synthetic glucocorticoids for other disorders. So very often for individuals for organ transplant. After they receive their transplant, they're on anti-rejection medications, which cause immunosuppression, and that induces depression, as well as some of the other physical characteristics that you see with Cushing's. Right. Weight gain, irritability, hair loss, those sorts of things. So we can essentially give this problem to somebody. I mean, in the service of saving their life, but clearly side effects. So we know that cortisol, this is the bad guy here. Okay. All right. So the good news about this, treatments by surgery or medication resulted in significant decrease in depression scores. So once somebody achieves biochemical remission, their symptoms of depression, anxiety, and mania get better as well. So post-operatively, progressive improvement of depression scores was found at 3, 6, and 12 months post-operatively in one study. And another study looked to and found that a year after cortisol levels returned to normal, rates of major depression and anxiety dropped to about 24%. So instead of 90%, we're down to a quarter of the population, which is still not good, but it's better than 90%. So there are significant improvements once the cortisol is under better control. Yes, ma'am. Excellent question. Between, I would say, I think it's 15 to 18% of the normal population, so it's really not substantially higher. So really good question. Okay. Yes.
The people that experience and stuff, do most get cured thereafter when they go into remission, or is it something that they continuously have to battle?
No, mania. Cushing's disease is entirely hormonally based. This is not like it doesn't induce, say, a bipolar disorder or anything like that. Once the cortisol is under control, the mania goes away and does not come back.
Gotcha.
Yeah. Mm-hmm. Okay. All right. So that's the good news. Here's the not so great news. Depression still remains the prevailing psychiatric diagnosis, along with an increase in suicidal ideation and panic disorder, even years after surgery in some cases. Now, this has been replicated in other studies where patients sort of anecdotally report persistent cognitive and psychiatric complaints affecting quality of life, even though their cortisol levels are normal. So essentially, people say, well, you know what? I don't understand. My cortisol is normal. I look better. I feel better. Why am I still depressed? And this really is kind of an open question. And so there's a lot of theories about it. And I'll just talk about some of them. So the question is, are these symptoms of depression, anxiety, are these due to changes in brain structure and function? Does the hypersecretion of cortisol cause permanent changes in brain structure or brain function that sort of predispose somebody for depression? Or is the emotional distress due to changes in quality of life following Cushing's? Or is it some combination of the two? I also have a hypothesis that, do people develop a sort of what I call a maladaptive somatic focus? So what I mean by that is, do people become hyper-focused after they have Cushing's disease that can contribute to the maintenance of depression or anxiety? So I see this a lot in individuals with chronic illness. So not just Cushing's disease, I see this a lot in patients with cancer who are in remission, particularly if the cancer was not discovered until late or they were brushed off by doctors beforehand, before they got the diagnosis. What happens is, they cough and they're like, oh God, it's lung cancer, it's coming back. Or you step on the scale and you've gained 2 pounds and you're like, it's coming back, the Cushing's is back. This is what, you brush your hair and there's more hair on the brush than there was before, and you're like, oh God, this is it. So, and this is very common following chronic illness, particularly when that illness is hard to diagnose and you feel like, perhaps you have not been treated fairly by the medical community and you have to be your own advocate. So it's a good thing because you can be your own advocate, but it can be a bad thing because you may be overestimating, a normal life event as indicative of something that's more catastrophic. I can't tell you how many people come in and they'll be like, you know what, I forgot my keys in the car the other day. And I'm thinking to myself, well, I brushed my teeth twice this morning because I forgot I did it the first time. But when you've been sick and when you've had these experiences, instead of thinking, this is just life, I've got a lot on my plate, instead you think, uh-oh, there's something wrong. There's something wrong with my brain. There's something permanently wrong with my brain. And so I wonder if this sort of somatic focus can serve to sort of reinforce depression. Because what ends up happening is you focus on the mistakes and you ignore other information that say, you know what, I might actually be doing pretty well. And in a way, to some extent, that is very protective because you have to be sort of on these things. I know I saw a lot of people writing down with the cardiologist, like, oh my gosh, I got to get on this. Like the next time you experience a little flutter, how many people here are going to be running to their cardiologist? I mean, again, it's a serious illness. You need to take it seriously, but it's almost a catch-22. It takes a toll on you emotionally. It takes a toll on your thinking. So perhaps could this lead to some of these kind of continued symptoms of depression over time? It's an open question and one that I would like to study. If only people would agree with me and give me some money to do it. Anyway, a different story. So really, I think that there is sort of, could there be permanent changes to your brain? Maybe. So one study in general, let's see here, have found that that the hippocampus gets smaller after Cushing's disease. So they found that, when people are in active Cushing's disease, the hippocampus, which is part of your brain that's involved in memory formation, gets smaller. However, that's been reversed following successful treatment of Cushing's disease. Interestingly enough, in the PTSD literature, they found the same thing, that people with acute post-traumatic stress disorder also show a shrinking of their hippocampus, which is reversed following successful treatment of their PTSD. So I will caution you all when you see these things saying, brain structure is reduced, atrophy is increased following Cushing's disease, you might think, oh my gosh, I've got brain damage. Well, not if they reverse it. Your brain is just like the rest of your body. Things can improve over time. It's not permanent. So I guess, my thought is don't panic. Everybody's not walking around with a hole in their brain apart from, the surgical resection. And that hole is really, not involved in your thinking. So again, just because people have found evidence of brain changes does not mean they are permanent. And it doesn't mean that they can't be reversed with appropriate treatment. So I do want you to keep that in mind. But it also means that there could be some, neurochemical changes in functioning that account for this persistent depression that you might be having. So again, people are like, well, it's all in my head. Well, literally, it might be. Right. So, cut yourself some slack. But as you can see, this area of research gets really messy because we're not just talking about structure, we're talking about function. And it can be very hard to tease, okay, what is due to a structural or functional change and what is due to just change in thinking habits around it. So this can be very difficult to study. And that's part of the reason why, there haven't been a lot of studies, because it is so challenging. Okay. So now let's talk about cognitive changes following Cushing's. So typically when people come to me or when Dr. Iamescu refers people to me, it's because people are concerned about their thinking. I feel like everybody's like, well, yep, I've got issues with depression and anxiety. I know it's due to cortisol. That's fine. Why can I not think right? I'm not as fast as I was before. I have difficulty with my memory. I have problems with my attention. So, people with Cushing's syndrome report a decline in their thinking. Specific areas of impairment that studies have found, and they're pretty consistent in this, include difficulties with attention and concentration, particularly more complex attention, difficulties in memory, and visual spatial skills, so not what you see, but how your brain perceives it, and executive functioning, which is essentially reasoning, and more specifically in Cushing's disease, kind of mental flexibility, being able to shift from one thing to another fairly quickly. And there's a reason for this. So several areas of the brain have very high numbers of cortisol receptors. So the hippocampus is probably the number one area that has a significant number of cortisol receptors in it. And the hippocampus, like I said, is the part of the brain that's involved in memory formation. Specifically, this is the area of the brain that converts short-term into long-term memories. So if you have damage to the hippocampus, you'll have difficulty learning and retaining new information. Information you already know, that's fine. But it's the new information, like what did I have for breakfast? Who did I talk to yesterday? Those sorts of things. The amygdala, which is responsible for our fear and our anger response. So again, a lot of that irritability that can persist afterwards, probably amygdala involvement. And the frontal lobes, and this is where that complex attention and executive functionings are sort of mediated in the brain. So, anywhere that there's a high allocation of cortisol receptors, this is commensurate to where people are noticing problems with their cognitive functioning. So that makes sense from a neuroanatomic point of view. Okay. And essentially, these areas, what they found is they experience volume loss in patients with Cushing's syndrome, which is thought to be due to excitotoxicity. Essentially, the cells are so activated they die. Again, what we see with successful treatment is that this atrophy reverses. Okay, so yes, the good news again. Structural changes in the brains of individuals with Cushing's syndrome are reversed following successful treatment. But again, you still have this issue of reports of cognitive impairment that persist despite long-term hormonal regulation. But this isn't well studied. For a long time, these were anecdotal observations. People would come into their doctor and say, yep, I'm in remission, I'm still having trouble with my thinking. And they would write down difficulty with attention and concentration. This was not quantified in any way. This was not formally assessed in any way. Now we're starting to do that in a much more formal way. So a lot of the early literature in Cushing's disease is based on patient reports. And very often what I see in neuropsychology is there can be a significant difference between somebody's subjective experience of cognitive problems and evidence of objective deficit because of that depression and anxiety again. What you perceive is, I never lost my keys before my surgery or my Cushing's. I have heard this from people. Come on, you have. But it seems different. You feel different in some way. So, you sort of say, no, I was much higher functioning before this. And that may be true. But we need to objectively evaluate that. And that's what neuropsychologists do. Okay. So why the reports of long-term cognitive changes? So there are some theories about why people have these difficulties. One is, even though the structural changes in your brain reverse, there could be a functional change. So again, perhaps there's a change at the cellular level that we cannot detect with neuroimaging. And those studies really aren't out there, but that's something that we need to look at. There may be overlap with persistent psychological symptoms because there is a lot of overlap between cognitive impairment and psychological impairment. So some of the core symptoms of depression, in addition to sad mood and loss of interest, are difficulty concentrating, problems with new learning and memory. Sound familiar? Right. So are these problems due to depression, or are they due to some of these brain changes due to cortisol? Don't know. Same thing with anxiety, difficulty concentrating, having difficulty focusing, poor sleep. Well, if you're not sleeping well, how well are you going to be thinking? Yeah, it gets messier and messier, doesn't it? On the plus side, there's great areas of intervention. Because of all these things that can contribute to these problems, we treat all the things that we can treat. We hit this on multiple fronts. Oh, you're not sleeping well? Let's work on that. You're having difficulty with your mood? We can work on that. And then let's see what's left. And maybe it's nothing, right? So again, very few studies, and by very few, I mean 0, studies looking at cognitive function in Cushing's disease control for the role of emotional functioning. So they'll say, we've done neuropsych testing on all of these people, and yeah, we're seeing problems afterwards. But we didn't assess their level of depression or their level of anxiety. So what is it, their depression or anxiety that could be causing these cognitive problems? We don't know. It's an open question. Yes?
And a lot of people that I know with pituitary and like total pituitary resection, doctors are now treating them with oxytocin. Deficient. Is that something that you recommend and you do in your practice with this? Because it's basically like something that the hormone we're never going to reproduce. Like I have no pituitary, so I make none of that.
Right.
And so sometimes, it's like things that should upset me, like, oh gosh, I just seen that dog get hit by the car, that sucks. But you know what I'm saying? It doesn't like,
you don't have that emotional response.
Emotional response
right,
is
exactly.
not there. I'm like, I look like I don't care because like it just isn't there. I'm like, I know it's not right.
Right, you don't get
But
that physiological.
But my body's just like, everybody's looking at me like, wow, look at that crazy fool. She doesn't even, but
right.
it's because my brain doesn't have that, it doesn't release like oxytocin to like stuff or different like hormones to make me act the way I feel. You know
exactly.
what I'm saying? I like feel
Absolutely.
it, but it doesn't show it.
Yep, you've got that. You've got the cognitive feeling of emotion, but there's no sort of biological expression or feeling of it.
Yeah, and I'm like, okay, people think, and I try to explain to them, like, look, like they cut my give a crap out. They did. Like, I don't have it anymore. Like, things that should bother me, it's just like, whatever, And that's good, I guess, in a way. But
right, as opposed to when your cortisol was out of control and you gave a crap about way too much. So,
that's what I'm saying.
yeah. The short answer is I don't actually recommend anything because I have a PhD after my name and not an MD. So what I usually do is I say, you should go talk to Dr. Iamescu. But I will say this, cortisol it's not just cortisol. It's all of these other hormones that go along with it. And so as little as we know about cortisol, we know even less about the role of these other hormones in terms of our thinking and our behavior. All I know is that hormones are powerful, and I respect them. They do. They run your entire body and your brain. And so, yeah, absolutely. Question in the back.
Just to add on to what she said, I'm blind on that side. I began taking the oxytocin about 6 weeks ago. I was suffering horribly from depression and anxiety, and I too lacked the give a crap. They removed it, and the same thing. I just didn't.
That feeling, yeah.
Exactly.
Yeah.
And so I was putting back testosterone, estrogen, doing all of that, and the last component was the oxytocin, and it's compounded, and apparently it's mostly compounded for people to be a little more amorous at home.
It does that too.
Because when I went to pick up the second bottle, he was like, "So is it working?" I'm like, and then when we talked a little further, I'm like, "Well, you know, I feel a little more engaged." Yeah, but there is that sense of detachment.
Mm-hmm. Yeah.
And I can only speak from my own experience, is that it is helping in that regard.
And so I think these are all important issues, and often issues that are not really talked about in Cushing's, because we talk, you go to your neurosurgeon, you go to your endocrinologist, and there's a lot of talk about biochemical remission, good surgical outcome. And I always laugh. I was like, a neurosurgeon's idea of a good surgical outcome is you're breathing, you're walking, and you're talking. You're basically, you're not dead. That's great. That is a good outcome from a neurosurgical point of view. From a quality of life point of view, things could be very different. Sorry, Dr. Ezekiel, I mean. You do good work. But often, there's some of these, let's say, more quality of life issues that end up in my office that, it's the higher level kind of stuff. Anyway. Oh my gosh, I'm in trouble. All right. Question.
So, as I've been looking at my mental health improvement and my cognitive, it's the same as the other aspects of my Cushing's, 2 steps forward, 1 step back.
Yes.
One of the things that I've been kind of really working on and looking at is, as Dr. O said yesterday, practice doesn't make perfect, it makes permanent. And for me, I've been looking at how long I had Cushing's before it was diagnosed. Some of my response systems were practiced over and over because of the cortisol.
Absolutely.
And so what, have you got protocols that you use now that help unwire the practice that you made permanent to create your new pathway for behavioral responses and working that mind emotive, the cognitive emotive connection to redo that? Because that's what I'm looking at. I was like, some of this is I have to unwire because my body automatically still responds sometimes, even though chemically that piece isn't there.
It's habitual now. This is your brain. The more you sort of experience something, the more habitual it becomes. And so yes, you need to unlearn those patterns. So really what I recommend is, in terms, really this is where psychotherapy comes in. All the medication in the world is not going to help with this because these are learned patterns of behavior. So you need to learn a different pattern of behavior. And it is very awkward at first, and it is very, I would say, not necessarily intuitive. So I am a big proponent of cognitive behavioral therapy. I think it works really well at unlearning those automatic associations. And that's really what I refer for people, particularly who have that sort of, like I said, somatic focus. Like you sneeze and you think, oh God, what's happening? My pituitary just came out of my nose. Something that like the catastrophizing that can happen. Because that probably saved your life before. And that probably was your life before. And so to unlearn that takes time and effort. And so, I refer a lot of people specifically to cognitive behavioral therapy because that is really sort of targets those automatic dysfunctional thoughts that we have and tries to retrain them. So I will actually be talking about that as well. Yes.
So I have kind of a short comment and then a brief question. So, the first comment I wanted to make was that I think for me, part of the issue is for 10 plus years, I believed it was just depression, anxiety.
Yeah.
And that if I'd tried harder, and then the term I almost used, because I believed it, was almost like self-gaslighting.
Of course.
Like extreme invalidation.
Yeah.
And I don't think I would be as depressed and anxious if I hadn't done, anyway, there's all.
But you may have been because your cortisol was out of control.
Yeah, that too, yeah. And then once I kind of got hold of the fact that I had to advocate for myself and no one else was going to, then I was like, well, this is terrifying. Anyway.
Yeah.
And then my question is, if I was going to try to talk to a neuropsychologist, do you have any recommendations? Like, just say I was exposed to really high levels of cortisol for a long period of time, or just anything you would suggest, or,
So typically, anybody who
Thank
has
you.
experienced Cushing's or high levels of cortisol due to to an adenoma or what have you, essentially, if you want to see a neuropsychologist, basically say that. I was exposed to this for a while. I'm concerned about my thinking. Can you evaluate it? And insurance pays for that. Yeah, that's kind of, I know that everyone, that's the $1 million question, because you're in a room with somebody for 8 hours and you're like, okay, what's this going to cost me?
I'm sorry, this is a follow-up comment. I made the comment, I talked to both psychologists and psychiatrists, and no one told me that this was, I kept saying something about testing, and everyone's like, I'm sorry, I don't mean to.
No, it's rare, and I will say, I think.
I love them, they're great, I think they just didn't know.
No, of course, and I think Cushing and the cognitive aspects, because psychologists, particularly clinical psychologists, when they see depression and anxiety and people are reporting cognitive problems as a result, they think, well, of course, this is your depression and your anxiety. So a lot of clinical psychologists don't have sort of the medical background, and that's why sometimes a neuropsychologist might be a better route, but we typically don't do a whole lot of therapy. We do a lot of testing. Yeah. No, you are, I would say, the norm, not the exception.
We're going to just hold questions for a few moments so that you can finish your presentation.
Sure,
and
sure.
just be prepared to be absolutely bombarded.
I can't wait.
Before you
Bring it. All right. Okay, so I only have a few more slides, but I wanted to, just again, talk about what's out there. So there have been only 2 controlled studies using cognitive functioning in patients with Cushing's using standardized neuropsychological tests. So these are objective measurements of cognitive dysfunction. The first study was a good one, but they only looked at people with active Cushing's disease, so prior to remission, and did not assess for the role of emotional functioning and cognition at all. What they found is very consistent with what people were reporting. Difficulties with complex attention, difficulties with speed of thinking, some of that executive functioning, again, being able to sort of think flexibly, some evidence of some visual spatial issues. So that was very consistent. A more recent study, I liked this one better. This was for people, because they had a lot of folks that they looked at, and they had a nice control group. So these compared neuropsychological performance in Cushing's patients in remission to controls. So the controls were matched for age, gender, education, and surgery. So the controls were people who had surgical history for non-functioning pituitary macroadenomas. So they also had TSS. So, some people are like, well, do people have cognitive issues just because they had neurosurgery? So this way you're comparing apples to apples to some degree, and the only difference is those difference in hormone levels. So again, they found impairments in memory and executive functioning in the Cushing's group compared to the controls in the pituitary macroadenoma group. And the specific difficulty in memory was difficulty with encoding, learning the information. People had more difficulty learning information, but they were able to retain what they learned. So let's say they had a list of 10 words. They were only maybe able to learn 6 of those words, but they were able to retain all 6 of those words. So that's the sort of memory impairment that they had. Now, this is the thing that killed me about this study. They actually assessed for depression, but didn't actually control for it in the analysis. So I still don't know, was this related to levels of depression or emotional distress or not? No idea. So, were the people with Cushing's in remission? Did they have higher levels of depression? And could that have caused those exact same memory deficits? Potentially. So there's really no way of knowing. But at least we've got something here. This is a great, I would even say, second step. Okay. So I wanted to end with just some of the clinical findings that we found. Again, this is not a formalized research study. This is just what we've seen in our practice over the past couple of years. And the reason, again, why I don't have a lot of good research on this is a fairly low number of people. So this is about 19 people that we've seen across 4 years. And in order to do some of these complex statistics, like in order to control for the effects of emotional functioning on cognition, you need a larger sample size. And of course, because this is a rare disorder, it's hard to get that large sample size. So, this really is, I would say, anecdotal data. This is not gospel. This is not formal research. There's your caveat. Okay, so with that in mind, this is typically what we do for patients that are referred in our clinic. So we do a cognitive assessment, including formal evaluation of effort, so test engagement, attention and concentration, speed of mental processing, language, visual spatial skills, learning and memory for both verbal and visual spatial information, executive functioning, and overall intellectual functioning. In addition, we also do a standardized clinical interview to look at emotional functioning, and we look at standard detailed self-report measures assessing psychological functioning, including depression, anxiety-related disorders, so panic, post-traumatic stress disorder, obsessive-compulsive disorder, mania, somatization, so that focus on bodily functioning, psychosis, and substance abuse. And so these are empirically validated, standardized measures that we use. So this entire extravaganza takes about 6 hours. The tests are short, but there are a lot of them. And like I said, the only way to see how a brain is functioning is to make it work. So this is not everybody's cup of tea, and I fully appreciate that. And so I'm pretty sure that the group that we've seen at Emory is a very self-selected group. So keep that in mind too. The main people who are coming to me are people that are concerned about their thinking. The people that aren't concerned about their thinking don't come. So take these results with a very large grain of salt. Okay. All right, so basically, this is just sort of summaries from 16 patients with Cushing's syndromes that were seen for full neuropsychological evaluations in our clinic from about 2014 to 2019. Their ages range from 22 to 59. Typical with most findings with Cushing's, the majority is female, 12 female, 4 males. Of the 16 patients that I saw, 4 patients had repeat evaluations over time. 2 of these were pre and post testing. And ideally, we'd like to get everybody pre and post testing. We'd like to see how they're doing with active disease and see how they do in remission. And the other 2, the dual assessments were both following surgery. 9 people had normal cortisol levels, so they were in biochemical remission. 5 people had elevated cortisol. And all patients passed symptom validity measures indicating good effort on testing. So this is, again, something that you can see in neuropsychological testing. If people are not engaged in testing, if they're too sort of overwhelmed by it, we have tests that sort of look hard but are actually easy. And, and we administer them to patients to see if they're actually able to engage in testing. So the good news is everybody that we have seen in our clinic has been willing to do this and fully engaged in testing. So I feel like I can trust the data that I have. Okay, so I just wanted to talk briefly about the pre and post-surgery patients because I think this is probably of most interest to everybody. So patient 1, we found cognitive impairments with decreased speed of processing in the mildly reduced range and mild impairment with new learning for visual information. Okay. Of much greater significance were emotional findings of acute mania, which resulted in hospitalization prior to surgery. She was also reporting lesser symptoms of both depression and anxiety at the time. Post-surgery, we repeated the tests. Cognitive findings found her speed of processing went back to normal. She continued to have some mild impairments with new learning for visual spatial information. So we still saw a problem there. The mania was gone, completely gone. Unfortunately, she was reporting increased symptoms of depression and anxiety relative to her first performance. And we really did think that the severity of that depression was contributing to her cognitive difficulties of difficulty with new learning. 2 years. 2 years. So, pre-surgery and post-surgery. Okay. Second patient, again, this was about a 2-year difference. Before surgery, we found decreased speed of processing, again, in the mildly impaired range. Moderate to severe impairment with new learning and memory for verbal information. So this person had a lot of difficulty learning and remembering new information and was very anxious. Okay, cognition memory. So we give people a word list and we say, was this word on the list? Was this word on the list? That was back to normal when it was severely impaired before. So there was still some residual difficulties, but not to the same level of severity. again, what we're finding emotionally, severe depression at this point and moderate symptoms of anxiety with higher levels than reported to surgery. And again, this was thought to be significantly contributing to some of those cognitive difficulties. So on both of these patients, it was really the emotional effects that were far worse than the cognitive effects. Okay, so now let's talk about our patients with active disease. So these are patients whose cortisol levels were abnormal and abnormally elevated. Okay, so all patients had significant symptoms of emotional distress. 5 out of 5 met criteria for major depression. 4 out of 5 had abnormally elevated levels of somatization, so that bodily focus. You know, I cough, instead of I have a tickle in my throat, I have lung cancer. That's kind of what I mean by that somatization. And 2 out of 5 had clinically significant symptoms of anxiety. Okay, and this, again, is very consistent with the reports that you see in the literature. So our clinical population is matching what you see in the literature. Okay. In terms of cognitive effects, 4 out of 5 had mild deficits with sustained and complex attention. 2 out of 5 had mild deficits with processing speed. 1 had difficulty learning new information, and 2 patients had no objective evidence of cognitive impairment. Every single one of these patients reported to me that they had significant cognitive problems. So the difference between their subjective experience and objective data was very different, and I have a feeling that that's because of all of that emotional distress. You know, keep in mind, cortisol is through the roof right now when people are seeing me.
Right, so maybe cognitively impaired from their baseline.
Exactly, and that does make it more challenging. We try to account by all of these tests are normed compared to people's age and education level. So where should you be compared to your peers? But no, it's very rare that somebody has a full neuropsych test before they get Cushing's. And so that's always a limitation to any neuropsychological study. But it is one that we try to account for. But yes, people are like, I'm not myself, again, but is it because of objective neurological changes in the brain, or is this because this cortisol is just, overwhelming you right now? And I have a feeling it's probably more of the former, but I can't rule out the latter, okay? How about the patients in remission? How do they do? So here's the thing that gets kind of tricky. A lot of people in remission also had additional radiation treatment. And I think the radiation treatment, we are seeing more cognitive deficits in patients that have radiation treatment than people who don't. But again, the cognitive deficits tend to be in this mild range of severity. So 3 of the 4 people who had radiation treatment had objective cognitive deficits on testing, and all 4 were endorsing symptoms of emotional distress, depression, anxiety, and somatization in that order. 6 patients that were in biochemical remission without any history of radiation, all of them reported consistent cognitive problems, because again, otherwise, why would you subject yourself to 6 hours of testing with me? 4 of the 6, though, didn't have any objective deficits on testing. None. 1 of the remaining 2 had deficits that weren't consistent with Cushing's. He actually had an undiagnosed learning disability. So I'm glad we found it. But 5 out of the 6 had clinically significant evidence of psychological impairment based on standardized psychological measures. Typically, it was either depression or somatization. So again, I think people become very attuned to their bodies and attuned to their thoughts. And this can, contribute to the maintenance of some of these symptoms. Okay, what do we do about this? That's kind of the million-dollar question, right? There's a lot of things we can do about this. So we really do need more research to see if residual psychological problems resolve with empirically supported treatments. So again, the best supported evidence for treatment of residual depression, anxiety, and sort of somatic over-concern is a combination of psychotropic medication. SSRIs tend to be the first line. Those are things like Prozac or Paxil or sertraline. And psychotherapy, specifically empirically supported treatments like cognitive behavioral therapy that work really well to sort of help us self-correct our thoughts that may not be accurate. So all of these people said, I have problems with my thinking. You know, those problems may be affecting their life, but there was no objective evidence of that. So that challenges the accuracy of some of those statements. And, you know, very often people were reassured that, like, okay, good, there wasn't any long-term, you know, changes from this. That's awesome. But why am I still having problems in my daily life? Again, this is what we're trying to address. So in patients that report consistent cognitive difficulties, several steps should be taken to evaluate concerns. One, we want to see, is there objective evidence of cognitive impairment? Okay, if there is, let's try to teach some cognitive strategies, some cognitive rehabilitation to work around them. Okay, you have difficulty with learning. Let's talk about using some strategies to increase your learning. If cognitive impairments are not found, but a patient has subjective symptoms, psychological factors are probably contributing to the problem. It might not be the whole problem, but it's probably contributing. We can deal with that. That's something we can really, we can address. So again, this is why I say cognitive behavioral therapy to reduce your focus on the perceived errors may be a good option. You know, I had a patient who came back, there is a word list of 16 words. You have 5 tries to learn as many as you can. She learned 15 out of those 16 words, and when she came back 2 weeks later to find out about the test results, she's like, I know I missed one of them. There's something wrong with my memory. I'm like, I can't believe you remembered, A, that you forgot one of them, and B, that you got 15 out of 16, which is 1 full standard deviation over the mean. And you remembered this 2 weeks later. Like, that is astonishingly good memory. And she was beating herself up about it. It's insidious. It happens. Questions?
So I have a statement and then a question. So
Absolutely.
I actually had the testing done.
And
I highly recommend it. One of the things that came out of it were several suggestions on going back to work. So I've talked to some people about that, and through ADA, America's with Disability Act, I worked with my boss on using some of those, and they gave me accommodations that have significantly improved my ability to do my job. So thank you for that, and I think even if you just use it for that, it is highly helpful. They put me in a different office. They help me. I mean, it's wonderful. So I highly suggest it for that. But my question, and this is, I'm coming in for, I don't know what you call it, cognitive rehab therapy in November. So we'll see how that goes. But
excellent.
What happened to me, and I'm not sure if you've seen this, is it got much better and then it got worse.
Yes.
So now I'm back to, I mean, obviously not where I was before surgery, but do you see that happen where it's like, all right, it's better?
That's
and
extremely common, yes. Yeah. And I think I have hypotheses as to why this might be. But one, when you initially after surgery, you feel so much better because your cortisol is not like out of control. And so compared to how bad you have been feeling, it's sort of dramatically better. And then you just sort of settle into your new normal. And that's, I think, where people are like, well, not everything is, you know, all sunshine and roses now. Like, I'm still noticing this here and this there. So that's incredibly common. And then also, of course, with Cushing's, the course can be unpredictable. So, you know, and so people are like, well, now I'm having difficulty with my attention. Is this the Cushing's coming back? Or is this residual? Or, you know, so this is sort of, yeah, or am I getting old? Exactly. And so, and all of those things can be at play. So, you know, I think having some objective evidence can kind of be reassuring. Like, you know, yes, I think my attention is worse, but objectively, no, there really hasn't been any changes, so that's a good thing. So maybe this just is life stress right now, or the fact that my job is, you know, my boss is being a jerk, or that my kids are now teenagers and, you know, they're stressing me out. I mean, so, you know, it gets very murky, and you're trying to figure out, well, what could be causing this? And of course, the Cushing's is always in the back of your mind. So, yes, that's extremely common. It does not mean you're going crazy, and it also does not mean your Cushing's coming back. But it's a hard, it's sort of, like I said, a catch-22. Yeah, and I'm sorry I don't have a better answer than that. Yes?
Sorry. one of my, all my symptoms were the memory type and the speech and all of that were changing. I had gone to a neurologist before I got diagnosed, and he looked at everything in my brain and said my brain actually looked good. But I did not go to a neuropsychologist.
That's fine.
And one thing I've noticed now, post-surgery, I'm 15 months, and things have gotten much better. But this new thing, I don't know, I just want to know if anyone else has this. It's almost like every day I wake up with a clean slate, and I don't remember the day before unless people bring things up. And I'm like, oh, yes. But pretty much it's like waking up like brand new day. Don't know what I did yesterday, don't know what bothered me, don't know who texted me. So unless I have everything like brought to the attention, is that a thing?
So the memories are there, you just have difficulty retrieving them spontaneously.
Or almost like I just don't care. Like unless somebody, brings it to my attention, oh yeah, we talked about that. Or otherwise I'm just like, good go, new day.
Well, the sun is shining, you don't have Cushing's anymore. I mean, maybe that's kind of what it is. And, perhaps take it as the gift that it is. I think there's a question. Oh, gosh. Okay, I'll get there, I promise. Okay.
I'm a college student, so I'm wondering if you have any, specific ideas of what college students can do to help these problems. I'm a senior, and I'm going to medical school. So it's a really big deal for me.
It is.
It's been getting worse, and is there anything you can recommend?
So typically we recommend academic accommodations.
I have one.
You have them already, and are they helpful at all?
Not now.
Okay. Then, and again, I think it's sort of an individualized, depending on the specific types of problems that you're having. But really making sure your disease is under as best control as it can be. That's obviously the first step. And then, using the accommodations that you have. And then potentially working with somebody on specific strategies, either, sort of tutoring or whatever it is that could be helpful. But I think, having an idea of what specific difficulties you have can really point to ways to address those. But yeah, it's a struggle, and particularly when you are involved in very high level kind of, type of work, because there's the physical issues too. You get tired, and then you can only sustain that level of intensity for so long, and you need to take a break, right?
My husband he was diagnosed in 2012 with atopic, and he had his tumor in his lung. I had a question about the homeostasis screen you had. Is there how do you go in between those two? Almost seems like he is one or the other, and to try to get, a normal in-between thing. And I don't know if there was any, recommendations on how to not be one or the other,
So if I'm understanding you correctly, your husband has a lot of sort of ups and downs, like very kind of what we call
Yes.
labile? Yeah.
And usually the downs come at the end of the day.
Mm-hmm.
And he has really rough mornings, then
Yeah.
he's okay, and then it all goes down again. But he is also seeing pain management as well. So, and it seems like the anger is, the kids don't want him to go to school with him because one time he got called to the principal's office, so, in Home Depot, it's just one, way up there, and then it's down.
So again, I think my suggestion would be a combination of pharmacology to help with some of that mood lability, and then also some environmental changes. So if you know that you hit 4:30 and that's it, anything that doing all the things that could potentially annoy him or induce some of these things at the time where he's at his best, where the pain is under control, or if there's a particular time of day where things are good, kind of stacking the deck in your favor, so to speak. So again, a combination of both medical therapy as well as environmental management is what I would suggest.
I'm just going to let everyone know we're going to take questions for 10 more minutes. Leslie's adjusted the schedule,
Sorry.
But you're still going to be bombarded. So.
Okay.
Just a quick question. Out of this test this experiment, whatever that you did, how many of those patients were adrenal? Versus
2.
ectopic versus pituitary?
Only 2.
Just 2 adrenal and the rest were pituitary, or?
I believe so.
Okay.
Yeah.
Thank you.
Mm-hmm.
I'm going to go on this side to be fair.
Okay.
have to get her. She's so in the back.
Dr. Panna, do you have any experience with, or is there anything in the literature of the use of like ADHD meds, Ritalin or Vyvanse or anything with this population? Would it be beneficial or?
You know, I haven't really seen that. Again, anecdotally, I wouldn't be surprised if people try it. The only disadvantage of using a stimulant medication, you know, pretty much, yeah, that's it. And so it can, you know, induce some of those feelings that we're really trying to get rid of, and particularly anxiety. So if you had a lot of, you know, kind of anxious or those sort of feelings beforehand, if you take a stimulant, it can kind of bring that back. So yes, it can help with your attention, but emotionally that might not be the way to go. So I would say that it would be highly individualized based on your own sort of course and symptoms, and definitely something that you should talk to your endocrinologist about, because that would not be something that I would feel like comfortable recommending given my lack of actual, you know, degree in medicine. Yeah, sure, absolutely. If it works, go for it. And if it doesn't, stop.
Yeah, how's it going? Like when you have the tumor, it's Cushing's disease, right? So when the tumor's out, the cognitive and physical problems, issues after the fact is Cushing's syndrome. Am I correct on that? Or?
Not typically. So Cushing's disease is specifically due to that microadenoma, but you can also have what's known as Cushing's syndrome if it arises from different areas in your body. Yeah.
I'm going to take advantage of the mic while I'm walking over.
Please.
I just want to, now I'm going to cry. I'm going to say since 2012, this has been the most validating 60 minutes, well, 60 plus minutes of my Cushing's journey. So from a call to action standpoint, you've insinuated a few times about wanting some grant opportunities. It doesn't have to be answered now, but if, and I can only speak for myself, but if there is a call to action that we as patients can do to help support that, with the caveat, I don't think any of us here have a couple $1 million to give you. But if I win the Powerball, you're right there. But if you could think about that, and how can we harness our individual opportunities to be a collective voice for you to justify this, please be there.
Thank you.
Hi, I have verbal problems and cognitive difficulties, so this is hard for me to get out. I just simply wanted to say, I'm also getting emotional now too. I'm about 20 years in remission. I've been consistently asking my doctors in psych for help with almost everything you mentioned, and I just don't want to leave here today and not follow up with this and find someone who understands that this is a thing. And I just, that's all I'm trying to say. I want to make sure I find someone when I go home to help me.
Yeah. Well, and, you know, again, like I said, these slides will, you know, absolutely everybody will have access to. But if you have specific questions about finding providers in your area, I'm happy to try to find folks, you know.
I feel like I'm going to give them the slide like I have been, and nothing's going to happen. And I just...
And it's frustrating.
Anybody, please help me.
This is a rare disorder, and this is a disorder that psychologists and medical doctors, honestly, you know, outside of the specialty area, don't have a lot of experience with. And, you know, I think there's not a lack of empathy, but I do think there's, you know, perhaps because it is so specialized, some lack of understanding about, you know, sort of the very real realities that people face. So I get it, and I'm sorry that this has been so frustrating for you. Yeah.
Does your testing show where you need help?
So typically what our testing shows is if there are sort of what we say objective cognitive impairments. So we do this based on sort of a normal distribution. So I consider, if you're performing 1 standard deviation below the mean as kind of a mild impairment, 2 standard deviations below the mean as a moderate impairment, and 3 is a severe impairment. So we can really say, okay, you're having difficulty specifically with sustained attention, and that's affecting your ability to learn new information, which is why you're perceiving this as a memory problem. So let's focus on increasing your sustained attention. That's kind of how we go about things. So we look at the pattern of functioning overall to try to see where to intervene. And sometimes, like I said, people are saying, I've got a ton of cognitive problems and they're not showing up objectively. So then we talk about, okay, subjectively, when do these occur and how can we help you sort of compensate for them when they occur? Is it just don't panic when it happens? That's a viable option. Or understand that, this is life, but it doesn't mean that there's any serious, brain damage. That's a viable option. Or, okay, this happened. What's the strategy I can use so this may happen less and I don't get upset about it? Mm-hmm. So, in general, I would say if you're not, there are really good neuropsychologists all around the country. Find somebody that's board certified. And basically it's the American Board of Professional Psychology. If you look up board certified clinical neuropsychologist, there's some in every state. Those are the people you want to go to.
We're going to have one more question, but if I could just add on, since the slides are going to be on there, I know that I have taken materials to doctors and said, this is what I want. So.
Mm-hmm.
Our neuropsychology, are you said you are PhD,
That's
not
correct.
MD.
That's
Is that
correct.
typical? So like if I needed prescriptions, like some people are mentioning prescriptions and I'm writing them down because like my internist, when I describe my apathy and other things like that, like one time I said, hey, I've heard that this can help patients like myself. She said, oh, that's called the California cocktail. I don't do that. So
wow.
I come in and I'm like, oh, really? That might be why it's on the internet. But so when I run into issues like that, it's interesting about getting she's an MD. I'm not.
Right.
So getting that prescriptive help as well. But would that be what steps would I take?
That's a good question. I'm not sure I have a fantastic answer because I think this is a common frustration that a lot of patients have. So all neuropsychologists are psychologists, PhDs.
Okay.
So we are familiar with medications, but again,
Right.
we are not prescribers,
All right.
and so again, we're sort of brain behavior folks.
Sure.
So often if you feel like, I tend to refer to, if you have a specific neurological or neuroendocrine problem, I really kind of refer you back to those individuals because oftentimes they have the expertise that a primary care doctor may not.
Right.
But again, it's up to the medical doctor to prescribe within their comfort zone.
Yes, of course.
And so that's the frustration because some doctors may not be savvy on Cushing's and say, oh, you're just, looking for medication.
Right.
So I guess choose your doctors carefully.
No, and that's fine, and that's an okay answer. I
Yeah.
just wanted to know if you knew something more than I did. Thank you.
No, not particularly. You're welcome. Thank you.